So, good afternoon, everyone. Let's start next session, poster discussion session, surgery and endoscopy. My name is Professor Andrei Klimenko from Zaporizhia State Medical University, Ukraine, and my co-moderator, Professor Roberto Valente. Please, Roberto.
Good afternoon, everybody. My name is Roberto Valente, and I'm a gastroenterologist at Umeå University Hospital in Sweden. Welcome to this very nice, interesting poster discussion session.
So our first talk, video grading of the pancreatic anastomosis during robotic pancreatic duodenectomy to assess learning curve and risk of pancreatic fistula by Bram van den Broek. Please.
So we're going to talk about with you the robotic pancreatic duodenectomy to assess the learning curve and risk of pancreatic fistula. I have no financial disclosures. As you know, the pancreatic RPD is a challenging procedure which requires a lot of practice. POPF remains the main contributor after RPD, and international studies show surgical performance has influence on surgical outcome. The aim was to assess learning curve of the RPD and to predict POPF by using the OSAT score. It's a multi-center retrospective study with a post-hoc analysis of the LEADUP-3 trial, and we included pancreatic duodenostomies after RPD. These were graded by two blinded graders using the OSAT score, and the main outcome was the combined OSATs of the two graders and POPF grade B or C. 153 videos were analyzed. POPF occurred in 23%. The median OSAT score was 48, and we saw a stabilization of the learning curve after 33 procedures. An OSAT score below 49, which was present in 50%, was associated with a higher risk of POPF and resulted in a relative risk reduction of 36%. To conclude, video analysis of the pancreatic anastomosis in RPD using OSATs identified a learning curve and reduced risk of POPF in case of better surgical performance. Video grading may provide a valid method to quality control and improvement.
Thank you for a very interesting talk. We have time for a small question. We don't have questions in chat. Probably I don't see a speaker. So
yes, I'm here.
Okay, so please tell me if this risk assessment of pancreatic fistula can be taken isolatedly out of patient conditions like soft pancreas or sex, age, obesity or so.
So there, I think it's two separate parts. The OSAT score is, I think, the best for the assessing learning curve, and by risk assessment with the patient characteristics. So you cannot, I think you cannot exclude patient characteristics out of the risk score. Also we corrected for the fistula risk score in the new in the OSAT scoring system.
Thank you very much. So we must move forward. Next talk is postoperative serum hyperalmelasmia adds value to the fistula risk score in predicting pancreatic fistula after pancreatic duodenectomy. Elisa Benon, please.
Thank you very much for the chance of being here today to talk to you about my project. The fistula risk score, easily FRS, is the most important tool for predicting a postoperative pancreatic fistula. Once implemented in clinical practice, the FRS has proven to markedly improve postoperative outcomes by segregating patients into discrete classes of risk. However, pancreatic fistula rates remain significant, as high as 20% even at high volume centers. The limit of the FRS may be embarking upon a prediction assessment at a single time point. where pancreatic leaks manifest temporarily over the course of the postoperative period, and the risk of a fistula may change over time. Recently, several early postoperative variables have been highlighted to be associated with a pancreatic fistula. For example, a postoperative serum hyperamylasemia, namely one of the diagnostic criteria for a post-pancreatectomy acute pancreatitis, and a well-known drain-through amylase activity and C-reactive protein. So this paper confirmed increasing FRS scores correlated well with fistula development, but once stratified patients for POH occurrence, the increasing incidence of fistula moving along the FRS risk zone was maintained in patients without POH, while in POH patients, the incidence of fistula was constantly over 40% in most risk zones. This is particularly important for patients previously classified at low moderate risk for fistula, with fistula incidence escalating 2 or 10-fold compared to the intraoperative FRS estimates. Such a significant stage migration associated with POH makes its identification critical. So we decided to test the added value of the postoperative biochemical values to the initial risk stratification using FRS. Fistula prediction significantly increased after adding sequentially drain-through amylase activity on postoperative day 1, POH estimated on both postoperative day 1 and 2, and C-reactive protein on day 3. So in conclusion, accurate pancreatic fistula forecasting should follow a progressive, dynamic, and iterative process, ideally starting in the preoperative setting and continuing through the operative anastomotic creation and continuously reprised along the course of the postoperative period. Through this, surgeon could potentially convert from a passive wait-and-see mindset about fistula development to a more active philosophy of surveillance and proactive interventions, guiding patient selection for an adapted ERAS protocol or drain removal or continuation. Thank you very much for your attention.
Thank you, Elisa, for very interesting talk, but we must be moving forward. And next talk is prevention of insufficiency of created jejunal anastomosis during pancreatic duodenal resection using falciform ligament of the liver. From Kharkiv, Professor Nikolai Veligotsky, please.
Our message is about prevention of insufficiency of pancreatic jejunal anastomosis during pancreatic duodenal resection using falciform ligament of the liver. The greatest risk of pancreatic fistula development occurs during operations on a soft, inflamed pancreas with sync of preoperative pancreatitis. Even with the most sparing precision technique of surgery pancreas tissue, leakage of pancreatic juice and the appearance of pancreatic jejunal anastomosis deficiency cannot be ruled out. Pancreatic duodenal resection was performed for 295 patients with pancreatic duodenal zone tumors. When accessing the pancreatic parenchyma, the following factors were given importance: inflammation, the degree of fibrosis of the pancreatic parenchyma, pancreatitis in the distal part of the pancreas, diameter, location of the Versum duct. 3 variants of pancreatic jejunal anastomosis were used: invaginating ductal pancreatic jejunal, invaginated pancreatic jejunal, pancreatic jejunal with falciform ligament of the liver bandage. Our results: low risk factors of the development of pancreatic fistula alveolar fibrosis changes, dense pancreas, a wide pancreatic duct with a diameter of more than 3 millimeters, a narrow isthmus, and sufficient mobilization of the posterior wall of the pancreas. High risk factors for the development of pancreatic fistula were the presence of a soft, inflamed pancreas, a narrow duct of Versum less than 1.5 millimeters, a wide isthmus of the pancreas, tension and eruption of Saturns during pancreatic jejunal anastomosis. With a soft pancreas, a method has been developed with the imposition of a precision invaginated pancreatic jejunal anastomosis with wrapping of the anastomosis suture line with the falciform ligament of the liver, patent of Ukraine. A sheet of this ligament was cut out 7-8 centimeter long and 2-3 centimeters wide. Place it of the anterior lateral surface of the pancreatic duodenal anastomosis. Fix it with separate automatic sutures covering the upper anterior and lower surface of the pancreatic duodenal anastomosis. And at the same time, one patient's development pancreatic fistula type B. Among 295 patients who underwent pancreatic donarization, biochemical leak was observed in 25 patients, pancreatic fistula type B 17, pancreatic fistula type C 8, erosive bleeding 4 patients. All patients with pancreatic fistula received anti-secretory therapy. For 14 patients with pancreatic fistula, the use of adequate drainage and conservative therapy led to recovery. 6 patients underwent minimally invasive interventions. 3 patients with soft pancreatic development, erosion, bleeding, with recurrent relaporotomy. Stitching of bleeding vessels with to fatal outcome due to recurrent bleeding. Thank you for your attention.
Thank you very much for the interesting decision. Unfortunately, we are 2 minutes run after time, so we move forward. Next talk, intraoperative blood loss estimation, hepatopancreatic biliary surgery, relevant non-standardized results from systematic review and the worldwide snapshot survey. Gianpaolo Peri, please.
Hello everyone, I'm Gianpaolo Peri from Verona University Hospital, and today I'm going to talk about intraoperative blood loss estimation in HPB surgery. So as you all know, estimated blood loss are considered a major quality marker and a predictor of perioperative outcomes in HPB surgery. However, the different methods at surgeons' disposal to measure blood loss are extremely heterogeneous, and there is no universal standard undermining the reproducibility of the results. So we designed a study which wanted to provide an overview on the worldwide practice of blood loss estimation during HPB surgery, and in particular evaluating heterogeneity and consistency of blood loss reporting, but also perceived accuracy and clinical relevance among HPB surgeons. In order to do that, we performed both a systematic review comprising recent study about liver and pancreas transaction and blood loss, and also a worldwide snapshot survey using the dissemination via HPBA and regional chapters, and reaching about 250 HPB surgeons. So those are the results of this systematic review. As you can see, as much as 60% of all studies, which were 806, had blood loss as a primary study outcome. However, 83% of all studies didn't even mention the blood loss estimation method. So in the few studies mentioned the blood loss estimation method, so only 17% of the total, 9 different estimation methods were found. The most frequently used in those studies was a calculation based on suction canister fluids, irrigation fluids, and gauzes. So regarding the survey, the majority of HPB surgeons systematically performed blood loss estimation. However, all 9 different methods were also found in practice in the survey. The most frequently used one was, again, the same as the review. But despite this scattered practice among HPB surgeons, the majority of surgeons perceived blood loss as a strong clinical predictor of postoperative complication in both pancreatic and liver resections. So concluding, EBL are characterized in the literature as a critical outcome metric during HPB surgery. And however, blood loss estimation methods are underreported, inconsistent, and lack standardization. The most frequently used one seems a calculation based on suction fluid, gauze weight, and irrigation. However, there is an urgent need to adopt an universal and standardized estimation method to ensure consistent reporting and reproducibility. Thank you very much.
Thank you very much for taking care of this important topic. We must moving forward. Next, present technical tips to optimize the surgical view during robotic-assisted pancreatic duodenectomy by Yosuke Inoue, please.
Hello, everyone. This is Yosuke Inoue from Cancer Institute Hospital. We Japanese people pray for peace in Ukraine. Today, I want to talk about the technical tips to optimize the surgical view during robotic-assisted PD. PD includes many sections with various locations and subjects of dissection. Robotic scope lacks flexibility or agile function to obtain wide or bird's-eye view. To optimize intra-abdominal view during robotic PD, we employ the multiple scope transition method. This slide shows the outline of our multiple scope transition method. We start robotic PD from laparoscopic abdominal exploration. Da Vinci Xi is first docked by a left position, then transferred to central positions, then finally moved to right position during resection sequence. Left position is used for SMA dissection from left side. It includes reverse Cocker maneuver, division of mesojejunum, and the detachment of pancreas head from SMA and SMB. Central lower position is used for dissection of suprapancreatic area, which include pancreas head exposure and turning of pancreas neck. Then, the scope is moved cranioventrally by turning the EZ axis 180 degrees. This position is useful for suprapancreatic dissection and hilar dissection. Then the scope is moved cranium to the right position, and this position is useful for SMA dissection from left side. This is our conclusions. Thank you for your attention.
Okay, thank you very much. Is the presenter here or not? No. So we are going moving forward. Next talk is
Here.
You're here. Okay. Could you please tell me, do you make breaks between parts of the surgery or not? Like coffee breaks or lunch breaks?
Yeah, after resection, we have a break.
1 hour.
But
yes?
during, yes.
For histology. Yeah. Thank you very much. Very interesting.
Thank you very much.
Yeah.
Thank you very much.
So next talk is management of clinically relevant postoperative pancreatic fistula related fluid collections after distal pancreatectomy. Giovanni Guarneri, please.
Thanks to the APC for the opportunity to present this study entitled Management of Clinical Relevant Postoperative Pancreatic Fistula Related Fluid Collection After Distal Pancreatectomy. My name is Giovanni Guarneri. I have no conflict of interest to declare. Fistula is the main complication after distal pancreatectomy, and the aim of the study is to describe the management of collection related to fistula and identify potential predictors of interventional procedures. 516 patients who underwent distal pancreatectomy were enrolled. 207 of them developed a clinical relevant pancreatic fistula. Among these, 153 patients who clinically demonstrated signals of infection such as fever, abdominal pain, or inflammation of the blood test underwent CT scan that showed a fluid collection in 130 patients. The first line of treatment was antibiotic therapy, which was effective for 60 patients, while in 70 patients, an operative management was needed, and it was performed radiologically for 52 patients and endoscopically for 18 patients. The following characteristics of fluid collection have been collected and analyzed on postoperative CT scans: dimension, air or blood content, drain present, and its effectiveness in draining the collection, wall enhancement, and fat straining around the collection. At multivariated analysis, the blood content in the collection, wall enhancement, and dimension greater than 5 centimeters resulted as independent predictors of an operative management. The two main differences observed between radiological and endoscopic approach were the presence of a surgical drain still in place, which is present in a significantly higher percentage of patients treated radiologically, and the pod of treatment, significantly greater in case of endoscopic management. In conclusion, fluid collection are common findings and key determinants for the clinical burden and management of fistula. In our step-up approach strategy, CT scan findings play a key role in indicating patients at risk of an operative management. Thank you.
Thank you very much. We are 1 minute after time, so we move forward. Next talk, outcomes of combined management biliary and gastric outlet obstruction, Gabriele study, a multi-center retrospective analysis. Giuseppe Vanella, please.
Good morning, and thank you for the possibility to share our data on combined biliary and gastric outlet obstruction. This is a very challenging scenario, even in the era of therapeutic US, as we have very few comparative data on the outcomes of procedures we can use in this condition. We performed a retrospective analysis of all consecutive patients with double obstruction who have been treated in 3 European institutions. We have enrolled 93 patients, mostly with advanced pancreatic cancer, for a total of 103 procedures combination. As you can see, we have found that the combination of enteral stenting plus use-guided cholecystectomy had a higher risk of primary failure when compared to other combinations. But above all, we analyzed the different risk of dysfunction during follow-up, ranging from the null rate of gastrojejunostomy plus hepatogastrostomy, 18% rate of gastrojejunostomy plus transpapillary stenting, 30% rate of gastrojejunostomy plus use-guided cholecystectomy, while we had a significantly higher rate for enteral stenting plus transpapillary stenting and enteral stenting plus use-guided cholecystectomy, 83% risk. And this is also confirmed at the Kaplan-Meier estimator of dysfunction-free survival. In conclusion, we already know that enteral stenting has a worse long-term outcome than use-guided gastrojejunostomy. This study suggests that use-guided cholecystectomy in the setting of gastric outlet obstruction may demonstrate suboptimal performances, while other procedure combination seems promising, as for example, gastrojejunostomy plus hepatogastrostomy and gastrojejunostomy plus transpapillary stenting, to be confirmed in appropriate prospective evaluation. Thank you for your attention.
Thank you very much. Roberto, do you have questions? Okay, so.
I think that it's a very interesting study, and actually it's just a comment, and it involves a lot of patients, because this is very, very common disease and complication after surgery. So I think it's very looking forward to see more prospective randomized studies on that.
Yes, we hope, and wish you all success. So next talk, exploring a novel composite diagnostic tool using non-contrast TUS, enhanced cyst wall microvascular imaging and cyst fluid analysis to differentiate pancreatic cystic neoplasm. Glenn Collet, please.
Exploring a novel composite diagnostic tool using non-contrast EUS-enhanced cyst wall microvascular imaging and cyst fluid analysis to differentiate pancreatic cystic neoplasms. My name is Glenn Collett. Here's my information, and here's my disclosure. Pancreatic fluid analysis has its role in clinical decision-making when multimodal imaging is unclear in differentiating mucinous from non-mucinous cyst, and when additional info may be required prior to surgery. However, as a standalone entity, its sensitivity is compromised when cutoff values increase and must be used in combination with cyst characteristics, by which itself also bears inconsistencies depending on operator experience. We aim to evaluate the usefulness of studying cyst wall microvasculature using high-definition imaging modality known as H-flow, which does not require contrast, in combination with cyst fluid biochemistry to accurately differentiate pancreatic cysts. We retrospectively analyzed 110 patients from 2 different Italian hospitals. Definitive gold standard accuracies was evaluated against surgical reports and radiological features from initial encounters. We then used Fisher exact test to look for correlation between a composite method and cyst fluid analysis. We found that The sensitivity and specificity of our cis fluid analytics were comparable to previously published data. Not surprisingly, when used in combination with H-flow, the diagnostic sensitivity and specificity rose remarkably, as shown in our slide. In conclusion, this new composite method, which utilizes high-definition imaging on EUS, is superior to that of standalone analysis of cis fluid biochemistry. It can be particularly helpful when applied to a holistic approach of combining cis morphology and EUS, vascularity, and fluid analysis alongside endoscopist expertise, which provides the most reliable way of diagnosing pancreatic cysts. Thank you.
Thank you very much. Unfortunately, we must be moving forward. The last talk by Cristina Martinez, Clinical Relevance of Pancreatic Fistula in Pancreas Transplantation, a Comprehensive Complication Index, based analysis of postoperative outcomes and prediction of graft survival. Please.
Good afternoon, my name is Cristina Martinez, and I will be presenting our study titled Clinical Relevance of Pancreatic Fistula in Pancreas Transplantation, a comprehensive complication index-based analysis of postoperative outcomes and predictors of graft survival. Pancreas transplantation is a curative option for patients with diabetes, but its morbidity is still high. A better understanding of its complications might help the clinician during the postoperative course. In this setting, a definition of pancreatic fistula is lacking, therefore its clinical relevance remains unclear. With our study, we aim to characterize pancreatic fistula in pancreas transplantation and to define its clinical relevance in the postoperative course and in graft survival. With this purpose, we ran a retrospective study of the consecutive simultaneous kidney and pancreas transplantations performed at our center over the past 10 years. Complications were graded according to the Clavendino classification, and the comprehensive complication index was calculated. Its complication was assigned a severity weight for the assessment of its specific average complication burden. Pancreatic fistula was described according to the original International Study Group for Pancreatic Surgery definition, which states that a pancreatic fistula is established when the drain fluid amylase is 3 times higher than the upper limit of the institutional value. Here are the results of our study. We had complete data from 78 transplantations with a median follow-up of nearly 45 months. As for the early postoperative course, patients which developed a conventionally defined pancreatic fistula had a similar comprehensive complication index that those who did not. However, drain fluid amylase and serum amylase did play a role as independent factors for poor postoperative course, but with different cutoff values. Perigraft fluid collections were also independent predictors of poor early outcomes. The independent risk factors for graft survival were the donor BMI and the prolonged cold ischemia time, in line with previous evidence. Perigraft fluid collections showed a mild association. Regarding all these findings, we can conclude that conventionally defined pancreatic fistula is frequent following pancreas transplantation, but its burden regarding the postoperative course and the graft survival is almost dismissible. Novel cutoff values might be considered to define a clinically relevant pancreatic fistula in future series, while perigraft fluid collections should always be taken into consideration for predicting both short and long-term outcomes. Thank you for your attention.
Thank you very much, Cristina. A short question. Why is it so that conventional definition does not work in pancreatic transplant surgery? Maybe because you treat non-cancer patients or non-orthotopic transplantation. Why?
Well, maybe it's because the physiology of the fistula is different in pancreas transplantation than in pancreas resection, because the parenchyma is not harmed as it's in the resection.
Thank you very much. So we close this section. It was an excellent section, great talks. Thank you all very much, and see you in Munich next year. And a few words, Roberta, please.
Thank you very much. It was very interesting session. I agree. Yeah, very looking forward to see you soon.
Bye-bye. Have a good day. Bye.